Thank you for inviting me to chair this session. I now invite the second speaker, Dr. Chih-Chin Kao, nephrologist and associate professor at Taipei Medical University. He is also the executive secretary and member of various committees with the Taiwan Society of Nephrology. Please.
Thank you for Professor's introduction. Good morning, everyone. It's my great honor to be invited as a speaker to join this exciting meeting. And I would also like to thank to the Asia Pacific Society of Nephrology for inviting me. APSN is a key organization that brings nephrologists across different countries to continuously promote the education, research, and the collaboration between countries. I'm glad to be part of this program. And I am Dr. Chih-Chin Kao from Taiwan, Taipei Medical University Hospital. Today, I want to share some of our recent work in AI and telemedicine in dialysis. My subtitle is Transforming Patient Care. It's APSN. It's my outlines. First, I will have some introduction. And second, I want to introduce some roles of AI and previous published some examples from literature review in dialysis patients. Then I will share some radar monitoring during hemodialysis in our hospital and the application of telemedicine in peritoneal dialysis patients. And Taiwan just launched the hospital at home program last year. I also want to let you know some of our work and the conclusions. So the first introduction. Dialysis generates substantial clinical data, making it ideal for AI applications. From the literature review, we know that AI and the machine learning in dialysis primarily focus on diagnosis, prognosis, and the treatment recommendations. We have a lot of unmet need in daily care of our dialysis patient. One of that is the prediction of intradialytic hypertension. It is difficult to predict, and we have some challenge for our fluid management and the set ideal dry weight for our patients. The conventional approach have some gaps due to infrequent monitoring of our vital signs and also some dialysis parameters and the delayed detection of the complications during the dialysis. Therefore, the innovation is needed for accurate, personalized strategy to predict and prevent complications. Some literature have shown that the roles of AI in dialysis patients. However, I think that until today, it is still very early stage of the AI application in our dialysis patients. The prediction of complication is what we want, including the intradialytic hypertension. We know that multiple patient-related and the dialysis-related factors may affect the results. In addition, the muscle cramping is often bothering our patients a lot, and it is also very difficult to predict. Another issue is the treatment optimization. Despite applying anemia guideline protocols in our patients still have sometimes have HB, hemoglobin overshooting, and fallen below normal, like called the hemoglobin fluctuations. Therefore, we want to use the AI and like the machine learning. They will integrate multi-model data and require large amounts of data for the training, validation, and the testing to help us to for patients' diagnosis and the prognosis prediction and sometimes treatment recommendations. One of the examples comes from CJSN 2021. It's a retrospective single-center data set. It enrolls thousands of data. They have some definition of the intradialytic hypertensions. And following the AI and machine learning process, they found that either the definition of the IDH, they have a very high AURC area on the curve. That means they can predict the intradialytic hypertension happening, about 90%. And they found that features include the age, sex, HD-related features, vital signs, clinical information, laboratory findings, and medications. Another example comes from 2 years ago. It is conducted in Korea. It enrolled also thousands of HD sessions data. They find that ADH occurred in 5% of all HD sessions. And they find the highest ranked features combining data from the previous 3 sessions with the best prediction performance. The top ranked features including the mean blood pressure and IDH in previous session, ultrafiltration target rate, and the pre-dialysis SBP. They use data for the training, validation, and testing. Another example comes from anemia management. They enrolled over 700 HD patients in 3 clinics. They used a 12-month control phase and followed by a 12-month observational phase using the AI-guided care anemia control model, using many parameters listed in this table, including some unchanged parameters and also some laboratory data to help them to predict the anemia. And the primary outcome is the HB fluctuation and the percentage of HB on target and the double-pointing dose. And I find out that using this AI-guided care of anemia, they will have a few fluctuation of the hemoglobin. In this figure, you can find that the interventional phase, the HB standard deviation is less than the control phase. And also, have the patient have the more time in the target range of the hemoglobin, and also the fewer median dose of double-pointing. Therefore, it seems that using this kind of AI help us, we can help our patient to improve the hemoglobin fluctuation. Another example comes from the fluid overload prediction. They use a portable ultrasound for diagnosing fluid overload, including the hemodialysis patient and the peritoneal dialysis patients. They use 8 points to diagnose whether they have the lung congestion. If the score more than 5 indicates the lung congestion. And they find that if we put the ultrasound on this side and using the AI to predict whether they have B lines for more than 5, they can say this patient have a lung congestion. They find that AI to detect B lines have good correlation with B lines observed by physicians. Therefore, they can help us to diagnose patients with fluid overload. In our hospital, we just launched the radar monitoring during hemodialysis for our patients. There are some unmet needs, as I previously said. This continuous monitoring, like we monitor the vital signs once to twice per hour. And some critical changes and physiological deterioration may occur during these gaps, and we cannot detect immediately, and delay the clinical intervention, like the patient's dizziness, nausea, or consciousness change. Therefore, we developed this kind of non-contact radar for our patients. It is just set in front of our patients, the bedside, and the upper world of our patients, and just near the patient and the machine. And use this radar monitoring, we can detect the patient's breathing and also some waveforms. This waveform can transform into our prediction of our patient's heart rate and the respiratory rate. Using this radar-based algorithm to estimate heart rate and the respiratory rate, combined with our patient's baseline data, including age, sex, BMI, and comorbidities, we aim to develop an AI model to predict the probability of hypertension and cramping, using each 30-minute window as an analysis segment. And using these signals, along with extended related parameters, data randomness, and the variability, to establish the predictive model. The characteristics of this radar monitoring is no contact with our patients, and we can have a continuous monitoring of our patients' vital signs, including heart rate and respiratory rate. And we also can detect the position change. So the early detection before the hypertension and craving events happening. We will integrate this radar input, combining with our patients' demographics and also some dialysis data from the machine. And from this case study, we can find that the patient, by the radar signals, we can find the patient have altered breathing pattern during the radar signaling. And then in the next second, the patient has the BP drop event, and we can adjust the dialysis ultrafiltration rate. So we are still gathering the data from our patients. We want to create a model to predict our patient have hypertension during dialysis. The next study is the muscle cramping. We also use this kind of radar signals combining with the dialysis machine signals to transform into the patient's breathing pattern and the events. We can find that the patient have the shallow breathing pattern and then increase the respiratory amplitude. Then in the next 10 seconds, the patient have the muscle cramping event. Therefore, we want to use this kind of radar monitoring system to predict our patients' complications during hemodialysis. Currently, we are now gathering the data from our patients, and we are now expanding our radar system in our 5 affiliated hospitals or clinics. We have more than 200 hemodialysis beds, and we have now scaling up and set up more than 50 radar systems in our hospitals. However, the AI application in the daily practice still have many challenges from the literature review and also in our actual clinical practice condition. That some reported that over-alerting burden. If the excessive alarms can become a burden for our physicians and also our team, medical teams. And another problem comes from the lack of transparency, maybe so-called black box on how predicted output developed in the AI model. Therefore, it will influence the physician's trust. In addition, the merging of multi-model data from the patients and also like the dialysis machine, it is a challenge. And the data privacy of our patients. Also, the generalizability across diverse population is also a problem. Therefore, usually may need to do the validation test in each situation. And the last but not least is the resistance to change among healthy care professionals. So the future advancement is that AI is not anticipated to replace physicians' medical decision-making, but instead assist them in providing optimal personalized care for our patients. And the effectiveness and the safety of AI machine learning tools should be rigorously and repeatedly evaluated. Then I want to go to the next part of my talk. That is application of telemedicine in peritoneal dialysis patients. Nowadays, we use a lot of wearable devices and biosensors in our patients, like the continuous glucose monitoring, a PD share source, the automatic upload of the data from the APD machine, and the last one, the HAH. We use the IoT for vital signs monitoring and the POCT. The patient may wear some of these devices at home, and their data will upload it to our telemedicine control center. And here we have 24 hours of faculty inside. And if there is any alarm or any abnormal data, they may contact with medical team, including the nurse and the medical doctors, to have feedback for our patients. So I want to have an example of my patient. It's a 76-year-old PD patient. He has a history of diabetes, hypertension, CAD, and the CKD stage 5, starting PD since last year, and also an ex-smoker. His occupation is previously a company owner, and the initial CAPD regimen is with 1.5 dialysate, 1 liter, 2 bags, and then to 2 liter, 2 bags. The medication of his is including some oral hypoglycemic agent and some medication for uric acid and vitamin D, diuretics, and erythropoietin. It is the patient's condition since last year. We can find that since he started his PD, his body weight is gradually increased, and also with his HbA1c. And we can find that during the body weight increase, he also have a kind of a lung congestion during the chest X-ray follow-up. And below is the medication. Initially, the DPP-4 inhibitor. And due to the increase of HbA1c, we added repaglynide for the blood sugar control. However, the HbA1c and the body weight is still high. And therefore, we apply the CGM, continuous glucose monitoring, for our patients. And we added the insulin, mixed insulin for the blood sugar control. After this initiated, the patient's HbA1c gradually decreased and the body weight gradually decreased. And due to the decrease of the residual renal function, therefore we also added, so the blood sugar uncontrolled, part of it because of the increase of the dialysis, I think. The use of CGM and the feedback from the CGM by our telemedicine center, we can find that the change of our patients from the July to August, we can find the patient have some lung of the very low glucose. Less than 70, we call the low, and less than 54, we call the very low. It is very dangerous for our patients. Therefore, they ask me, and I adjust the insulin dose for my patient. In the next month, we can find that the very low and the low glucose is improved. However, we can find that the patient still have not much time in the target range of the blood sugar. Therefore, we still adjust the insulin gradually. We found in the next month, the patient has very high and high glucose, more than 60% of the time. Therefore, we adjust the insulin dose, and we find that the glucose is improved. The time in the target range is more than 70% of the time. Therefore, I want to let you know that in this case, we apply the CGM and help our patient have better glucose control and also the body weight. Another example comes from the PD shared source machine. This machine helps us to proactive patient care, can improve the transparency of PD patients' compliance at home, and the automatic upload of the patient treatment data also help our team to make some change, like the alert to some treatment events, and easy to adjust the program for our APD, like the cycles and amount for our patients. Therefore, this machine also helps us a lot for our PD patients' care. And I also think that it is also part of the telemedicine. And last part, I want to introduce our hospital at home program in Taiwan, launched since last year. Because of the bed available in the hospital, and also the very busy of our emergency department, and also because of the nursing staff do not want to work anymore in the hospital. Therefore, we launched this kind of system since last year. We can do some treatment at home and let our patients do not need to hospitalize and the treatment at home. We have some three recommendations of our patients, including the home care cases, or the facility residents, and the emergency department cases. And this patient should be restricted to three main diagnoses, including the UTI, pneumonia, or cellulitis. And also have not so good functional status. We call it like the basal index less than 60. After our team's evaluation, if the patient is fulfill the criteria, then we can enroll the patients into treatment at home by our HH team. We use the IoT for the vital signs monitoring and use the telemedicine. Like the previous said, the data we upload to our telemedicine center, and if there are any alert or alarm data, they will contact our medical team, including the nurse and doctor, to get the response. Then after the treatment finish, they can be discharged, but he is already at home. So it is our real picture that our HH team, including our emergency department and also hospitalists, our infection men, and also community medical team. They do the home treatment by our nurse team and telemedicine by doctor every day. So it is our telemedicine center. Our doctor will contact via the video and also the computer to see our patients at home and to prescribe medication for our nurse. And our nurse will go to patient's home to give the treatment. So we also do some point of care testing at home and vital signs monitoring. This is summary of our HAH cases since this year. Our affiliated hospitals have more than 100 cases. Most of these are UTI, and most of the cases come from the emergency department. Okay, I want to go to my conclusions. AI is applied as a support system designed to extend doctors' insight and assist medical decision-making, rather than to replace the critical judgment of our physicians. Our non-contact radar monitoring during hemodialysis could help early detection of IDH and cramping, and we want to have more data in the future. By applying telemedicine, including the CGN, shared source, and HH, we can improve our patients' care. Thank you very much for your attention. And in the last, I want to invite you to join the next month's meeting of our TSN and APCN annual meeting in Taiwan. Thank you very much for your attention. Thank you.
Thank you, Professor Chih-Chin Kao.